You are welcome to my channel. I'll be talking about temporomandibular joint syndrome. The other name for the same condition is temporomandibular disorder. The temporomandibular joint connects your jaw to the skull. It is a hinge and sliding joint. Another definition here is that a syndrome is a collection of signs and symptoms, meaning you are going to listen to so many signs and symptoms here. What could have caused what at this joint? Well, in a bit we'll know that. How can I know that this is all about temporomandibular joint? How is it treated? The signs and symptoms of temporomandibular joints will vary depending on what is causing it and which part of the skull. Like I said, the joint is connecting the mandible to the skull. Okay? The temple area, that is the meeting point of all the bones of the head, the skull, the frontal, the temporal, sphenoid, or parietal bones. Where they meet is the temple area, and that could be located on the side of the skull. When you trace your eye backward, it's at the back of the eye between the forehead and the ear. That is the temple area. The temple area is very thin and weak. And the reason why this has become the first part that I'll talk about is that it has middle meningeal artery beneath it. So any trouble there can lead to bleeding into the brain. When there is pain along this region, pain at the temple area, we don't joke with it because of that probability that we might not know what has happened to the middle meningeal artery. Because if in any way, in any form, it has been damaged, destroyed, or cut, and bleeding has occurred, the individual can bleed into the brain, having cerebral hematoma. Other signs and symptoms will include jaw pain, pain while chewing, jaw clicking, jaw popping, and the muscles of the jaw area could become stiff and painful, and there could be locking of the jaw. And how will you know about that? They will rather tell you that they can't open the mouth when you try to tell them to open the mouth because it's locked. And it might not be limited to the jaw area alone. There could be headache, facial pain, ear pain, earache, or popping sounds in the ear. There are certain risk factors that may be associated here, like poor neck posture, poor upper back posture, chronic inflammatory diseases like giant cell arthritis, rheumatoid arthritis, osteoarthritis, and some will actually have genetic link to this, that this is common in the family, allodynia and connective tissue disorders. Causes could include teeth injury, jaw injury, malalignment of the teeth or the jaw, teeth grinding, teeth clenching, and poor posture. Still, part of the causes could include trauma like blow or impact to the head region, arthritis like rheumatoid arthritis, gum chewing for a long time, disc erosion, disc malalignment, cartilage destruction secondary to arthritis. And when we can't find because of any medical condition, we have something else to say, and that is idiopathic. There are certain facts here. This is usually a temporary condition that will resolve on its own. You may need to do nothing if there's no pain and if there's no limitation of movement. But you have to see a dentist if you can't open that mouth, please. You have to see a dentist if you can't close the jaw. You have to see a dentist if there's persistent pain or jaw tenderness. What are the possible differential diagnoses here? We might be dealing with trigeminal neuralgia, headache that could be tension headache, migraine headache, or cluster headache. And this might be secondary to dental caries. And this might be gingivitis. Other differentials might be maxillofacial injury, mandibular dislocation, mandibular fracture, giant cell arthritis, rheumatoid arthritis or osteoarthritis, gout or pseudogout, or it might be sinusitis. How do we make the diagnosis here? A thorough history, and of course, a thorough physical examination. The physical examination should involve a patient for tenderness, and you ask the patient to open and close the mouth. And while doing that, we note the range of movement. X-ray should first be done, and dental X-ray will be appropriate with or without the skull X-ray. CT scan could be done based on your judgment and the availability. Temporomandibular joint arthroscopy could be also embarked upon. Now the treatment. I call this treatment A because I'm going to divide the treatment into different portions. In A, it means you are going to do nothing. Many people will not need anything at all and they'll get out of the problem. So, the whole situation could be scary at the beginning, but could end up being a self-limiting condition. Many people will do nothing. Let me tell you a story here. I had this, and I did nothing, yet I got out of it. In B, that is non-pharmacological intervention. Here you can give mouth guards, oral splints, mouth exercise, ice packs, moist heat, no more teeth clenching, no more teeth grinding, no leaning on chin, no biting of fingernails, eat only soft food items. Someone is saying, why soft food items? Because you just don't want to put much stress on the mandible, again on your jaw as a whole. Avoid chewing gums. Avoid biting hard stuff. This is not the time to start cracking the bones. No. The C will be the alternative treatment. But this is just an expedient thing to do because we need to tell you the truth that alternative treatment is available, but in my practice, no, I don't do that. So you can have acupuncture, you can have relaxation techniques with biofeedback. Now, treatment D. If everything from A to C is not working, so it means B, non-pharmacological intervention has failed. C, the alternative you tried, to those who will try, majority will not, but nothing is working, then we'll start medication. Ibuprofen, Tylenol in Canada, paracetamol in US, in other parts of the world, acetaminophen generic, may or not combine ibuprofen and acetaminophen. You may and you may not. If you are not winning with those, then you can start low-dose amitriptyline, a tricyclic antidepressant. And you can add muscle relaxant like Lyriza or baclofen as the generic name. If you haven't successfully relieved the patient of the problem up to D, then might be a referral for Botox. And if you are skillful and comfortable to give corticosteroid into the joint, you may try that, but if not, please refer to another physician who could do that. But Botox and corticosteroid injection to the joint is welcome when non-pharmacological, pharmacological, they are failed, or the patient has tried alternative, not winning, then Botox and corticosteroids could be tried. Finally, if you tried everything, A, B, C, D, E, and you're not winning, then surgery. Please refer appropriately. Arthrocentesis could be done with joint irrigation to remove the debris and inflammatory byproducts. Temporomandibular joint arthroscopy will now be embarked upon at this juncture, and modified condylotomy, that is mandibular surgery, could also be embarked upon. And some surgeons will actually carry out open joint surgery of that temporomandibular joint. And with that, I've come to the end of this very presentation. The takeaway here is temporomandibular joint syndrome or disorder could be self-limiting in many patients or many people, but that is not the end of it. We need to know what is responsible for it. That's why I've listed the possible causes, the risk factors, and the other situation is it might even be another thing entirely. That's why I listed the differential diagnosis. And of course, how we can make the diagnosis, and you could see A, B, C, D, E, F, the different ways to tackle this problem. In all, contact your physician on time. When you get this done on time, then you will save many things, particularly when there is temple area pain. Your physician will want to know what has happened to the middle meningeal artery. Remember to share this presentation. Remember to subscribe to my channel so that you can get all my presentations immediately they are published. I appreciate it.